The second part of the IV module includes intravenous medication administration. As with giving any kind of medication, you always need to do your 5 rights and your 3 checks. Check for IV compatibilities, which I will go over with you in a little bit. The correct dilution, any kind of adverse effects or side effects that your patient may have, the action, the absorption, the metabolism, and excretion rate. And also, you need to know if there's any antidote that is available for your medications that you're going to give. Know that administration of IV medication is within an LVN scope of practice according to the Texas Board of Nursing. The role of an LVN is to administer IV fluids to stable patients and medications. They can adjust IV flow rates to stable patients according to the healthcare provider orders. They can insert IV catheters, and they can monitor for clinical manifestations of adverse reactions to IV fluids or medications. Know that some agencies allow LVNs to give certain types of medications IV push. You need to make sure that you check your facility policy to see what you are allowed to give. There are different ways to administer IV medications, either through a large volume, which is what we call a primary bag, intermittent or small volume, which is known as piggybacks, for example, antibiotics, tandems, which I will describe later, mini infusers, which is like a PCA pump, and IV push and bolus. Medications can be added that are compatible to primary bags, and this usually consists of 500 to 1,000 ml bags, and it's given continuously. We always use a pump.
With primary fluids, again, this is a medication, so you will have to have a doctor's order. This is normal saline. With primary fluids, medication and other additives can be added to primary IV bags, such as folate, thiamine, potassium, but that would be added by pharmacy. With primary fluids, you need primary tubing. So I have an order to hang normal saline at 100 mLs an hour. An easy way to remember with these bags how to open it is there's usually a part up here that you would just tear and it comes right off. Make sure the bag is not expired. I would get the bag, I would hang it up on the pole. Then I would get my primary tubing. With the primary tubing as well, it has a little ridge that makes it easy to open. And I would take out my primary tubing. Now, depending on where you go, there is different types of primary and secondary tubing based on the type of pump. This pump is called an Abbott or a Plum pump, so I need to have a specific type of primary tubing for that. This one's been used, but they would always be new in a facility. But in lab, you're going to have used ones. With the Abbott or the Plum, it comes with what's called a cartridge. So what I would end up doing is trying to unwind. This would have a cap on it. I would take the cap off and not touch this because this is considered sterile. Now I'm going to go to my bag, and what's going to be kind of different for you is that with these bags, there's a little magic trick. Are you ready to see it? I would pull this off, and look, nothing's coming out. Because this is a brand new bag, so until I spike it, I haven't broke the valve. When you're in lab, these bags are going to be used, so the magic trick won't work. Then I would come, make sure my cartridge is closed by pushing this, or if it's on a roller clamp. I'm going to come over here, and then I'm going to spike my bag. Now, once I spike it, I'm going to go ahead and squeeze the chamber and get it to about halfway full. You usually use a trash can, but I'm going to use this bucket because I have to prime my line. If I don't prime my line, then I would be inserting all of this air into my patient, which would give them an air embolism, and we don't want to do that. So I would take my cap off. There would be a cap on the end of this. I would take it off, and I would just hold it. Now what I'm going to do is, because of this type of tubing, and again, you will practice this in lab, is I would go ahead and open it, and you would see it dripping, and I'm going to have to put it upside down, and this is what you'll do in lab, upside down until this cartridge fills. Then I'm going to flip the cartridge, and then I'm going to let it go until I see that I've pretty much got all the bubbles out. With brand new tubing, this is going to go very quickly because this tubing has been used before. It's going to take a little while. plugged, I follow this all the way, and I make sure I have no bubbles, and then it starts to drip out. Then I'm going to go ahead and clamp and put my lid back on because I need to keep this sterile. Then what I can do is I'm going to come to my pump, and then I will just insert the cartridge into the pump. Once I put it into the pump, I can get my pump and program it, but not started yet. I would go to my patient. If I haven't already made sure that I have flushed the patient's IV to make sure that it's patent, I would do that at this time. Again, I would have gloves on, and then I would come and connect this to the patient, program my pump, and start it. That is primary IV bag and primary tubing.
If you are at a facility where you have to mix medications into your primary bag, please make sure that you label your bag with the medication and how much has been added. An intermittent infusion is also what we call a piggyback. This is a small volume, anywhere between 25 mLs to 200 mLs. And it's in an IV bag that is usually connected to a primary bag at the upper Y port. I'm going to show you a video here shortly so you'll see what I'm talking about. One thing to remember is that the primary bag does not infuse at the same time as the piggyback does. What will happen is the piggyback will run, and then you will program your pump that then the IV, the primary bag, will pick up right afterwards. Let's watch a video.
Now it's time to hang an IV piggyback. What you're going to do is get your IV piggyback. So for example, we'll say that this is ANSA. I need to make sure that my IV piggyback is compatible with my IV primary fluids running. Once I have determined that it is compatible, I can proceed. So I would get my IV piggyback, which is an antibiotic. It's the ANSA. I would open it up. Sometimes these are a little bit trickier. I have my primary fluid already running. Then I'm going to come and hang up my piggyback. I'm going to get my secondary tubing. Secondary tubing is shorter than primary tubing. Again, find the little bridge. Opens a lot easier that way. With the plumb pump, you don't need the hanger, so just discard that. Now what I'm going to go and do is make sure that you clamp this, okay? I'm going to take this cap off. I'm going to come over here and do that another magic trick. Are you ready? I'm going to pull that, and look at that. Sometimes it's really hard to pull, so just make sure that you're aware of that. I'm going to come over here and again make sure that you've clamped this. I'm going to go ahead and spike it. Now, I'm not going to put anything in this fluid because I'm going to show you in a minute how you're going to back prime, okay? So now I'm going to come, I have a cap on the end of this one. When we talk about piggybacks, that means that we're going to connect it to the port that's above the pump. Now, I know this isn't really above the pump because it depends on the type of pump that you're using, but this is above. I would come over here, I would scrub, again, I have gloves on, for 15 seconds. Then I'm going to take off my cap, come over here, it's a little ridged area, I'm going to push and twist it on. Now what I'm going to do is I'm going to open this up, I'm going to have to come to my pump, and I'm going to have to say it's running, the A is for the primary, the B is for the secondary. I'm going to have to come over here and say stop. There's a button right there. And I'm going to have to hit my back prime button and watch what happens when I open this up. You can see how it's taking from the primary bag and it's filling up all the way to the secondary bag. I would keep doing this all the way until I get fluid into this pump. Once I have back primed the secondary tubing all the way until I have the chamber about halfway full, I would go ahead and program my pump. This is something that you're going to do when you get into the skills lab. The nice thing about these pumps is that it knows the way that you program it, that this will run in over a certain amount of time. For example, if this is 50 mLs and I need to run this in 1 hour, then my rate would be at 50. So after an hour and it takes all of the antibiotic, the pump automatically switches and it goes back to the primary bag. Something else I need to make sure that I go over with you is you need to check your facility policy to see how often do you have to change IV tubings. At Seton, the tube. Usually you will see that they'll just peel off the end. I would come put it on and just put it across itself. All tubings need to be labeled. If they are not labeled, then we usually will have to discard them, and then we would have to get new tubing. So please make sure when you hang any kind of tubing that it is labeled, and you need to be looking when you go in your patient's room. Is it time for me to change the tubing or not?
Now, a tandem is a little bit different than an IV piggyback. A tandem is also a small volume, but instead of connecting it to the upper Y port, you'd connect it to the lower Y port. Now, I don't have a video to show you this, but what I want you to think about is that if I'm going to have to connect it to the lower Y port, which is closer to the patient, I'm going to have to get a separate pump. And what this means is that the tandem and the IV primary bag will be running at the same time. When you have a piggyback that's running with or connected to a primary bag, it is not running at the same time because it's on one pump. If a patient were to have a mini infuser, such as a PCA, this also would run as a tandem. You have to make sure that all tandems or PCAs are compatible with the primary IV fluid that is running. An IV push or a bolus is a little bit different. With this, you would be drawing up medication in a syringe, and you would connect it directly to the patient's IV if they were to have a saline lock, or if they have continuous fluids running, you'd connect it to another port. If they have continuous fluids that are running, you have to make sure that whatever medication you're going to administer, IV push or bolus, is compatible with the fluid that's currently running. An IV push is exactly what it sounds like. You're just going to directly push in the medication. But remember, once you push in medication, it's very dangerous. You cannot take it away. So it's very important that you're looking up what the medication is that you're giving it, how fast of a rate that you need to be administering it, like maybe say you're going to give Zofran and it's over 1 to 2 minutes, what kind of side effects that you would expect to see from the patient. Now let's watch a video about IV push.
Let's talk about drawing up medications for an IV push. For this scenario, I have Zofran. I've already done my 5 writes and my 3 checks. Though this is not attached to a patient, we're going to have to pretend that this is attached to a patient. We've already started an IV, and this is the end of my extension set. So, I'm going to, my patient has what's called a saline lock. Remember, a saline lock means that they don't have continuous or anything going through the IV at that time. That's what a saline lock means. So I have an order to give Zofran 4 milligrams IV push in a saline lock. This is a peripheral line, so I would get my syringe. You can get a 3 or 5. This is a 5 ml. I'm going to get a blunt tip catheter and attach it. I'm going to get my Zofran, and I'm going to wipe the end for the 15 seconds. The whole time I would have gloves on, just remember that. This is 2 milligrams per ml. The order is for 4 milligrams, so I need 2 mLs. So again, I've already wiped the top, and I have my gloves on. If it was a multi-use vial, again, I would need to draw up 2 mLs of air. Insert the air. Draw out my 2 mLs of my Zofran. Now we're going to do what's called the SAS, which means saline, administer the medication, saline. I would have my gloves on, I would go to the patient. I've already done my ID, my 5 writes, my 3 checks, like I said before. I'm going to juice for 15 seconds. I'm doing it faster just for videotaping purposes. Then I would get my syringe, a pre-filled syringe of the normal saline. For a peripheral line, even though this is 10 mLs, you only need like 3 to 5 mLs. Now let's remember, why are we doing a flush prior to administering medication? Well, we're doing it because we want to make sure that the vein is still patent. So I would flush, and as I'm flushing, I would be looking at the vein, looking to see if there's any kind of infiltration or phlebitis. asking the patient if they have any pain during that time. I'm going to push pause 3 to 5 mLs of the normal saline. And I'm going to take this off. Check your facility policy to see if you would need to get another alcohol pad to clean for 15 seconds. Then I'm going to get my medication. Now, just for time purposes, I'm going to say that I need to push this medication over 2 minutes. I would come over here, I would get my watch, and I would, over 2 minutes, push the medication. Then I'm going to get my last syringe of flush, and remember, because this is just a peripheral line, I only need 3 to 5 mLs. I'm going to, I've already cleaned if I needed to. I'm going to push it on here. Now remember, it still has medication in here, so we need to go slow at the beginning. So I'm going to go really slow for the first like 1 to 2 mLs, and then if I want to finish at the end, I would just push pause, push pause. That's what we mean by saline, administer, saline. That is SAS.
There are a lot of different factors that you have to consider when you're giving any kind of IV push medication. So let's use the example of Phenergan. Phenergan, the order here would say maybe 25 milligrams, which really we only give 6.25 milligrams now. IV push every 6 hours PRN for nausea and vomiting. Well, of course, you're going to have to do your 5 writes and your 3 checks. You're going to have to look in an IV drug book what is the rate of administration. So maybe it says for each 25 milligrams, give over 1 minute. So if you have 6.25 milligrams, it's safe to still give that amount over 1 minute. You have to check and see if the medication has to be diluted or not. With Phenergan, it's highly recommended that you dilute it because it is so toxic on the veins. If you have IV fluids that are already running, whether it's a primary bag or a secondary bag, you have to see if Phenergan is going to be compatible or not. Check for any kind of side effects that the patient may have. Maybe there is an antidote that's available. And also for any contraindications that maybe if the patient had any kind of bone marrow depression or BPH or an allergy to this type of medication. There is also something that's called speed shock. It's whenever you give the medication too fast. Signs and symptoms that you'll see with your patient is they can complain of a headache, they can get dizzy, very flushed face, chest tightness, irregular pulse, and even worst case, cardiac arrest. That's why it's very important that you assess and find out how fast are you to give any kind of IV push medication. Other factors to consider are adverse reactions to any kind of medication that you're giving IV, allergic reactions, toxicity, like it's very common with elderly patients or people who have renal or hepatic issues. Know any kind of therapeutic levels that you may have. Like for example, with vancomycin and gentamicin, most facilities will have a peak and a trough that's ordered for these medication. Be careful to look for dig toxicity and dilantin. These are all drug levels that it's important as a nurse that you are monitoring. Let's do a critical thinking exercise. It's been 15 minutes after hanging an Ansef IV piggyback infusion to a client who is complaining of itching and is flushed. What action should you take first? The answer is stop the infusion and then flush with normal saline and contact the healthcare provider. What are some other signs and symptoms that should be assessed? How about vital signs, infusion rate? See if the patient's having any kind of difficulty breathing or complaining of shortness of breath. And also see if there is an antidote. Let's do another exercise. The dose order reads Visceral, 75 milligrams, IV push, every 8 hours, PRN for itching. Dose on hand is 100 milligrams per ml. How do you prepare this medication? How many mLs will you administer to your patient? The answer would be 0.75 mLs. Let's talk about parenteral nutrition. There are 2 different types, PPN, which is known as peripheral, and TPN, which is known as through a central line for total parenteral nutrition. So what does this mean? TPN or PPN is also known as intravenous or IV nutrition feedings. It's a method of getting nutrition into the body through the veins. In other words, it provides nutrients for a patient who do not have the functioning GI tract or who have disorders requiring complete bowel rest. So let's think of it this way. What's the best way for you to obtain nutrition? Well, we would eat, and that's what normally most of us do. We eat food through our mouth and it goes through our digestive tract where we absorb a lot of the nutrients and vitamins through our small bowel, and that's how we get nutrition. If for some reason somebody is not able to eat by mouth, say for example a patient's had a stroke, then the next best thing would be to give some type of tube feeding, whether it be through a Dobhoff, which is short term, or maybe more long term would be a PEG tube. Now this isn't the same as eating like you and I would do, but it's the second best because the gut and the small intestines is still able to absorb the nutrients and the vitamins. Now, when something's happened to a patient and for some reason, like I said, their GI tract is unable to work properly, we can't let the patient starve. So we're going to give them a parenteral nutrition, and that's where TPN and PPN come into play. Any patient who is on any kind of parenteral nutrition will always be malnourished because remember, there's not enough of this to be able to give to a patient that their body can naturally absorb through the GI tract. Here are just a few reasons for somebody that would be requiring TPN. Maybe they have limited or no oral intake and they're unable to digest through the GI tract. Their serum albumin level may be very low. Again, any kind of GI disorders, renal or hepatic disorders, or just poor tolerance to enteral feedings. Remember that TPN must be given through a central line and it cannot be combined with anything else, meaning if a patient were to have a central line and they had double or triple lumen, TPN could go into one of those lines and then primary fluids or piggybacks could go in the other line. You cannot attach anything else to TPN line. It has to be given by itself. As with any other kind of IV bags of any kind, it's only good for 24 hours. So at the end of the 24 hours when TPN has been hanging, you must discard it and get an order for a new TPN bag.
Let's talk about TPN and PPN. PPN is parenteral nutrition, which means we're going to be giving the medication through the peripheral. It's not very common because it is very vesicant. TPN stands for total parenteral nutrition, which means we're going to give this medication through a central line. You may have a type of TPN or PPN that is a bag that's yellow, and you may have one that's white. With these two, the difference is that this has lots of different kinds of medication that's been added to it, such as amino acids, dextrose, calcium, potassium, sodium, and you can even add insulin. Now, what is this bag? If it's separated, that means that what makes it white is the lipids. So these are the different types of TPN or PPN that you may see.
Again, just remember that TPN has to be given through a central line, and these are just examples of a central line. TPN is very costly as well because it contains so much different types of electrolytes and medications and minerals and even vitamins. It usually comes anywhere between about a 2 to 3 liter bag. With TPN, a new TPN order has to be written by the healthcare provider every day. A nutritional consult is also required. Electrolytes are monitored every day. Even daily weights could be very important. Accu-checks are usually done every 6 hours. Eyes and nose need to be checked, albumin, vital signs, and sometimes even a urine analysis. There are different types of complications from having TPN. Mechanical usually means that this is from the insertion of the catheter. For example, if a patient were to have a subclavian central line, sometimes a pneumothorax could occur after the catheter has been placed. Infection, this is just from a central line infection. Electrolyte imbalances, and also fluid imbalances. This is why it's very important to be monitoring the patient's eyes and nose. Okay, now it's time for a couple of questions to see if you know the answer. First answer, how long does it take for pharmacy to make a TPN bag usually? the answer can be up to about 4 hours. This is why most facilities are requiring a new TPN bag to be hung at 6 p.m., but new TPN orders must be obtained by 2 p.m. That way they don't have to worry about the TPN bag running out. Which leads us to our next question. What do you do if the TPN bag runs out before a new one is made? The answer usually is to hang a bag of D10 running at the same rate that the TPN bag would be hanging. Now, you just need to check your facility policy to find out exactly what they would want you to hang, but that is the norm because they're afraid of a patient having a rebound effect of hypoglycemia. Which now leads to our third question. Why are AccuChecks done on patients receiving TPN who are not diabetic? High blood glucose values are a common metabolic complication of TPN, which is why the AccuChecks are usually assessed every 6 hours. So you need to make sure that you're explaining to your patient why they're having AccuChecks monitored, even if they are not a diabetic. And also, the healthcare provider may order a sliding scale of some type of insulin, and this is also important for you to explain to your patient that it's only while they're on the TPN. Because remember, when we can keep our blood sugars at a normal range, it promotes healing. Here are just a few nursing interventions that you will need to be monitoring and assessing for when you have a patient who is on TPN. Maintaining nutrition. It's very important that you are monitoring their I's and O's for fluid volume balance and also their daily weights. Monitor all lab values and any kind of changes that you may need to notify the healthcare provider about. Make sure that you're assessing even around the central line for any kind of infection, because this is sometimes known to happen. Vital signs should be also performed. Sometimes it's every 4 hours, but again, you just need to check your facility policy and your healthcare provider orders. Monitoring their blood sugar levels like we discussed earlier and administering insulin if needed. Promoting activity if possible. This will maintain muscle tone. And also providing the patient with any kind of information as needed that will help with their knowledge about why they were on the TPN and signs and symptoms to be looking for. This concludes the IV medication lecture